Well, I guess we'll start. Welcome today to the University of Waterloo. I'm Shirley Fenton, Managing Director of the Waterloo Institute for Health Informatics Research. Thank you for joining us today as we continue our Smarter Health Seminar Series on health informatics tools for the future. We also welcome those that are joining us through our live webcast. The recording of this seminar will be available on our website. If you haven't found this so far, it's at http://hi.uwaterloo.ca. Hopefully we'll have the recording available on the website by next week. A special welcome to our speakers, Michael Connolly and Brendan Seaton from Smart Systems for Health Agency. I've had the pleasure of several very interesting discussions with them, and I know today will be equally enjoyable. A special thank you to our seminar series sponsors, McKesson, Mayo in Canada, and Healthcare Information Management and Communications Canada. Without them, we couldn't do these seminars. Before we begin, our next seminar is Wednesday, June 22nd. Our guest speaker is Sam Maricchiotti. He's the Vice Chair of the Ontario Hospital eHealth Council. Very busy man. He's also Vice President of Corporate Strategy and Development and CIO of Sunnybrook and Women's College Health Sciences Center. So we'll look forward to his talk. He'll be speaking on eHealth in the province of Ontario. Now, usually at this point, David Johnson is here to introduce our guest speakers. Unfortunately, David was not available to be here in person, and he still wanted to introduce Michael and Brendan. So, with a little bit of magic, we've managed to have David with us virtually.
I'm so sorry that I'm not with you all today at the seminar, particularly because Mike Connolly and Brendan Seaton are your guest speakers. I know Mike and Brendan well, and I'm just delighted that they're here with us today. I have the pleasure of serving on the board of directors of Smart Systems for Health Agency, of which Mike is the Chief Executive Officer and Brendan is the Privacy and Security Officer and wise counsel to the agency. Smart Systems for Health Agency is a bold experiment. It is an initiative of the Ontario government, now some years old, to take the networking for all health information and health services outside of the Ministry of Health and into a kind of crown corporation which would have a degree of independence from government, which would be particularly sensitive to privacy and security matters with respect to health data, and which would be very responsive and client-friendly in establishing systems to manage the information about the health of citizens of Ontario and ensure that we have one of the leading electronic communication systems for health in the world. That responsibility has been entrusted to Smart Systems for Health Agency, of which Mike, as I said, is the Chief Executive Officer from its very beginning, and Brendan has served it in the specialized role. Mike has a long history of health information systems initiative and leadership. In fact, I regard him as the Dean of Health Information in Canada. He began with the Ministry of Natural Resources in Ontario, and then for over 2 decades has been the pioneer in developing various networking systems for health in and around the Ministry of Health, and now heading this semi-arm's length agency. Brendan occupies an area of great importance in this modern information technology world, balancing the need of ensuring rapid and substantial movement and analysis of information and making it widely available while at the same time protecting privacy and security. An area that, of course, has been important to us at least since the beginning of the printed word, but becomes particularly important when information is so ubiquitous, so fungible, so easily available through systems, and able also to be penetrated by inventive minds and others, and requires a very artful balance of the different interests at play. And so I'm very sorry that I'm not with you all to hear Mike and Brendan today, but I know from hearing them many times on earlier occasions that you're in for a very, very interesting session, and I wish you all well. Thank you.
Well, thank you very much for inviting us here, and we actually looking forward to questions at the end. So as we're going through, please jot down anything you can think of with respect to this subject that ask us, because we're quite interested in getting feedback, and a lot of feedback we'd like to get from the academic environment, because, quite frankly, healthcare in this province hasn't utilized the academic environment as much as they should, and that's one of the things that we're here to do, to try and work with Dominic and his band of merry men and women. So any sort of a question is what I'm really trying to say would be appreciated. And now, next. What we want to talk about today, basically three things. What is Ontario's eHealth vision? And I'll do that very quickly and briefly, because the meat of the subject here is focused on managing risk. Okay? How do we manage risk within the Smart Systems for Health environment, and as a result across the eHealth sector? And then just a couple of words about what you can expect to see out of the eHealth arena over the next 1 to 2 years. Okay? What actually will be happening on the ground that you could actually see if you went to a hospital, or see if you went to a doctor's office, or see if you went to a dentist, for that matter, wherever. So first of all, I want to lay out a little bit of the layout of what the governance structure is for eHealth in Ontario. Up here we've got the Ministry of Health and Long-Term Care, and within that ministry they've established something called the eHealth Office. Now, you probably think, well, gee, they've got all kinds of offices inside the Ministry of Health, but this is actually quite a major step forward. Within the ministry, the eHealth Office is on the same level as OHIP is. Okay? It's on the same level as the drug program, the Ontario Drug Benefit Program, and it's a program of the ministry. And I know that may not sound like much, but believe me, this is an extremely important milestone in getting the government's focus on eHealth. If you go to Management Board of Cabinet, they will now understand eHealth. To them, it's the same sort of thing. It's a major initiative. They're focused on it. You can discuss it with them and they understand it, as opposed to it being buried in a whole variety of different programs within the ministry. So I can't stress how important getting eHealth elevated to the level of a program was in this province, and that just happened in the early part of this year. Before that, it was spread out all over the place, and so there was no focus, no real center that the government could look to. Now, the role of the ministry in the eHealth agenda is primarily policy. Okay? In the past, they've been responsible for policy. They've also been responsible for developing application systems, like a lab system for the province or a public health system for the province. They are changing their role, in the process of changing it as we speak, from that service delivery and policy into straight policy. Okay? They've set up Smart Systems for Health Agency as the delivery arm for that policy. So, as Dave mentioned on the tape there, we've got responsibility in Smart Systems for Health for infrastructure, for networks, for data centers, for identity management systems, and a whole bunch of things like that. And we now have responsibility for computer systems that are across the whole health agenda. So lab systems, pharmacy systems, systems to be installed in doctors' offices, etc. So they've moved a lot of the function out of the Ministry of Health and into this agency for delivery purposes. This eHealth Council is, there are a set of eHealth councils in the province, one for every sector. So there's a physician eHealth council, there's a public health eHealth council, there's a lab eHealth council, etc. They're composed of people from the sector, representatives of the sector, and the senior executive from the Ministry of Health who is responsible for that area. So the assistant deputy minister who's responsible for dealing with hospitals would be on that council. The hospital council, the assistant deputy minister who's responsible for docs would be on the doc council. And there's an overriding council that reports into this eHealth office and into the minister. And it's made up of the heads of the other councils, basically. They're appointed by the minister, and they make recommendations as a whole to the government on what should we be doing with respect to eHealth in this province. So there's a hierarchy of councils that make recommendations and, in fact, do most of the policy recommendations that go into the ministry. So, in fact, if we have a security issue, privacy issue, some policy around it, Smart Systems would make a presentation to the eHealth Council, the Ontario eHealth Council, who would then make a recommendation to the Ministry of Health. So this is not a bunch of bureaucrats sitting in the ministry trying to map out the eHealth strategy and agenda for the province. It's being driven primarily from the bottom up by the actual healthcare providers. And it's been quite effective. The healthcare providers over here get their services from Smart Systems for Health. So they get their networks from us. By the way, they're all, quote, free. Right? They're obviously not completely free, because if you're putting a 50 kb line into a hospital, for instance, they have to do something inside their hospital in order to connect to it, and they have to manage their connection. They've got to manage their firewalls and do this sort of thing. But for the most part, the services that come out of Smart Systems for Health are free. Okay? So some of you may have heard of Canada Health Infoway, and the question that comes up fairly often is, how does Ontario's eHealth strategy and their governance structure relate to Canada Health Infoway? Well, the fact of the matter is Canada Health Infoway is simply a funding mechanism for getting some of the projects going with respect to eHealth. So effectively, as projects come along, we go and talk to Canada Health Infoway and see if we can get funding for those projects. They have no governance relationship whatsoever to the activities within the province. Yeah, so that gives you a layout of who all the players are, how they relate, and the governance structures around it. This little diagram is actually trying to demonstrate that we've got all of the basic, and this isn't all of them obviously, all of the basic eHealth sectors, all the health sectors, they are working through a common SSHA provided infrastructure, common privacy and security mechanisms, common standards. Something I didn't mention, and it was on the previous foil, there is a eHealth standards body in the province now. We didn't have one until quite recently, and that has been established and is operating, developing standards for use in eHealth in Ontario, and linking into the federal and to the international standards bodies. And then there's this thing called eHealth Solutions, and as I mentioned before, that's something that the ministry did a lot of in the past, and we're starting to migrate those applications over into the Smart Systems for Health area. The objective is that I've got a healthcare provider somewhere who's dealing with a patient. That healthcare provider will be able to look at that patient's record, the important parts of it, the parts that healthcare provider is allowed to look at, and be able to do it through their desktop, or their BlackBerry, or their whatever device it is they're using at the time. So we're trying to get all of the information that's important from all of these sources about a patient and getting it to the healthcare provider at the appropriate time and as they need it. How many of them are there? There's somewhere between 150,000 providers and around 24,000 sites that we need to connect up over the next couple of years. We've done a lot already. The obvious thing, improved patient care, more effective providers, integration, better use of financial resources, etc. Everything you'd expect to get from automation. something that's not on these foils, in my opinion, is more important than anything that's on there, is that we'll get information, we'll get data about what's going on in the health sector. And that data can be used for research purposes, and that data can be used for health system management purposes. And right now, the data that we collect, for the most part, is for payment of medical claims, or payments to a hospital for funding their hospital. It's not good data for research, and it's very poor data for health system management. My analogy on the health system management side is it's sort of like the cod in Newfoundland, right? You've got a bunch of people over here who want to eat the cod, and you've got the cod over here, and nobody in the middle managing it, and as a result, the people ate all the cod. Well, the same sort of thing's happening with the health system. We've got doctors, and we don't know how many there are, and how many we need, and hospitals, and all this sort of thing. And if we're not careful, if we don't manage this system, right, it will deteriorate to be more like the U.S. system. We won't be able to fund it all. The costs will skyrocket. And so we desperately need this data that's trapped in doctors' paper files and hospital paper files and all over the health system. So that's not on this slide, but to me it's a very, very important aspect of what we're doing. Get us some data so we can manage this system. What do we not do? Okay, well, we're not in the business of hospital information systems. So we don't create hospital information systems for University Health Network or Sunnybrook or London Health Sciences, this sort of stuff. That's the hospital's job. We're not into, and for the most part, we're not into the business of creating systems, the operational system that supports the day-to-day operation of a healthcare provider. So we wouldn't write a clinical management system for a doctor. What we would do is go out and acquire the ability for doctors to easily get one of those systems and put them in, help them put them in, but we wouldn't write the systems. Okay? So for the most part, we're not in the business of what's right on the provider's desk. Other than that, and we're not in the policy business. That's the government's thing. Other than that, our job is to do basically the rest of the stuff with respect to eHealth in the province. A couple of slides here. Basic two things, common infrastructure and the business solutions that I talked about. We do get directed in what we're doing by the Ministry of Health and Long-Term Care. We're 100% funded by the Ministry of Health and Long-Term Care. So all the network costs, the data center costs, all that stuff is paid for directly by the ministry. We are, as David Johnson was saying, an arm's length agency. We have a separate board, but we do have to comply with the general policies of government. So we can't just go out and procure things willy-nilly. We have to go through a competitive procurement process and all this sort of stuff. However, one of the really important things about Smart Systems for Health is that we're not allowed to share the information, patient information, personally identifiable information with anyone except those people who are authorized to use it. So those people are typically a doctor or a nurse or a healthcare practitioner. Under no circumstances are we allowed to give that information to the government. I mean, we're absolutely mandated that we cannot give it to the government under any circumstance. Right? And so we're a sort of a trusted third party. We're set up to be a trusted third party that healthcare providers could trust to look after their information for them and make sure it doesn't get into the wrong hands as it moves through the system. So we're a trusted third party, and we're legislated, like I said, in that way. So we can't, we can't collect data from a doctor on the doctor's practice habits or anything and give that to the government. We can't collect information about the patients and give it to the government. We can't do anything except give the information back to the people who either entered it or to the patient themselves. If they ask for their own record, obviously we can do that. Now, our infrastructure, we've got, remember we had two things there, business applications and infrastructure. The infrastructure is really fairly straightforward. There's data centers, there's networks, there's security infrastructure, as Brendan will talk a bit about, And then there's the support infrastructure. There's a great big help desk and things like that. So when people have a problem with the system, the network goes down or whatever, they can get support. The data centers are absolute state-of-the-art, redundant data centers, instantaneous rollover. If a system goes down in one data center, it's like 300 or 400 milliseconds before it's back up in the other data center, and it's totally transparent to anybody using the system. So that's the basic infrastructure. Sounds easy, but it isn't easy because there are tens of thousands of locations, every type of network connection you can imagine. It's connecting to every type of technology you can imagine. So it's quite an interesting technical challenge to try and get all these connections together and get them organized and do it in a secure way. So we've got secure hosting, network services, portal services. I didn't mention that. I'll do that very quickly. A lot of healthcare sector providers have asked for some generic portals that they could use to allow them to look at multiple different systems concurrently. It's standard portal services. So we provide portal services for people like the doctors at community care access centers, etc. Secure email. Seems like a funny thing to be on a list of email, but the number one priority of the broader health sector when we asked them was, give us secure email. One of the people got up and said, for God's sake, there isn't a large company in the world that doesn't have an email system, and what we've got here in Ontario is one large business, the health sector business. And we've got approximately 2,000 or 4,000 email systems, none of which can communicate, and it's a major issue. So they really wanted something that sounds simple, secure email. It doesn't actually turn out to be that simple, but it is something that we are in the process of providing as we speak. Registration services, we've got to know who these people are. We've got to make sure that who's at the end of that network is who they say they are, and not somebody pretending to be somebody else and rooting through databases or stealing people's email messages or watching videos for telehealth applications. Contact center, electronic health records, standards management, privacy and security. Spend 2 seconds on electronic health record. When we did a survey and asked people in the health sector what they were really interested in, what their highest priorities were, email was number one. Electronic health record didn't even make their top 10 list. Okay? However, we do know that electronic health record is something that we need. It's the holy grail of where we're going, but it's not, it's sort of, in Stephen Covey's language, it's important but not urgent. They don't want it tomorrow. They want a whole bunch of other things. They want connectivity. They want some security, identity and access management. They want directory services. They want email. They want some hands-on access to lab data. They want the history of a patient's lab data. Instead of just getting a lab test result back, they want to see what were the last 10 results of this type. They want to see the same thing for drugs. They want a whole bunch of stuff. So it's interesting. The literature all talks about electronic health record, and other than the institutional electronic health record, so an electronic health record within a hospital or within a long-term care facility or within an individual doctor's office. Those things they want, of course, because it's automated their business process. But this electronic health record across the province or across the country was not the highest thing on their priority list. Who's eligible for the Smart Systems for Health services? So who do we go and connect up? And you can see it's just about everybody. I mean, it's public health units and homes for special care, Aboriginal health centers, substance abuse, addiction, just about everybody. This is probably not even a complete list. So the idea, in its summary, focus the eHealth agenda in one arm's length agency from government, free it up from the constraints of government, make it, quote, free to all of the healthcare providers so they don't have to go in and try and get the money for it out of their existing budgets and go and argue for all this stuff and get more funding, and do that quickly. Okay. One last thing before I go on. One of the drivers for this, one of the things that has really got us accelerated on it, was the SARS episode in Toronto. Okay. At that time, we had no, hard as it may be to believe, we couldn't even send out a proper set of emails to all the healthcare providers telling them what the latest status was on that particular episode. And people who did get information got stacks of it like this. It was disorganized. It was very difficult to follow through. We couldn't track anybody for quarantine systems because nobody had been quarantined for 50 years in Ontario, so there were obviously no computer systems for it. They couldn't track people to contact management to see who'd come in contact with this person with the disease. So it was sort of a crisis, small, but very, very focused crisis, almost entirely in Toronto, but it really got the ball moving on this stuff. So I'm going to turn this over to Brendan, who's going to go on to the next topic, which is the whole trust problem inside the Ministry of Health, risk problem.
Thank you very much. And I'd like to thank Dominic and Shirley and David for inviting us here. I'm going to talk to you about the whole question of managing risk. Obviously, as Mike said, we've got a very complex infrastructure, very sensitive information, very critical information in terms of making decisions about the health care of individuals, and as a result, it poses a significant number of risks. And at the Smart Systems for Health Agency, we've had to take a very considered approach to assessing risks and then appropriately managing them. Managing risk in our products and services, we address risk in three critical areas: the area of privacy, the area of security, and the area of safety. Now, there are other risk issues as well. There's a number of business risk issues, for example, human resource, technology, financial. We deal with those as well at the agency, but in terms of our products and services, we really focus in and direct our energies on those issues that could have significant implications for either patients or healthcare providers. And we found that this triumvirate of privacy and security and safety are all key. And all of our products and services, and when I say products and services, it was that list that Mike had shown for us, the secure email, the hosting, the network services. All of them are subject to a process we call certification and accreditation, which I'll talk a little bit, which is really how we manage risks after we've identified them. There's a number of tools and techniques that I'll talk about very quickly over the next 20 minutes or so. We'll talk a little bit about privacy, security, and safety design principles that are actually built into our products and services. Privacy impact assessments, threat and risk assessment, hazard risk assessment, and then the certification and accreditation process that I've talked about. Privacy, security, and safety design principles. The key thing as we start thinking about building privacy and security and safety into systems is that what we realize is that, generally speaking, what we're talking about is good business practices and good information management practices. It's a lot of people get very concerned about when you start talking about privacy and security, thinking that it's something new or mystical that has to happen. But what you really find when you go in to start designing the actual solutions, it is really just good information management and business practice. And of course, it's much more economical to build privacy and security and safety into the actual design process rather than trying to retrofit your systems after the fact, which is very typically what happens now in health information systems. So what are these design principles? Well, first of all, we take a very close look at the interests of the patient and who's really at the center of our service delivery model. And what are the patient's interests? Well, the patient is interested in their information remaining confidential. They have that bond of trust that they have with their healthcare provider. We have to make sure that bond of confidentiality is addressed. But they also want to make sure that the information is available when it's actually needed for the delivery of their health care. If I have a heart attack and I show up at the local hospital, I would really like to have my information that might be in my electronic health record or my personal health record in my home in Scarborough available to the doctors and nurses who are treating me here. So that availability is really important to the patient as well. Integrity, the information has got to be accurate. There can be no chance of this information being corrupted or modified in the process. The patient is interested in privacy. We all have very specific rights that have been granted to us by virtue of privacy legislation. We have the right to control our personal information, control who it's disclosed to, who uses it, how, what purposes it can be used for. So we have to address that, and we have to address the whole issue of safety, because obviously I don't want to be harmed. The issue of patient safety is a very big issue, as you all know, throughout the entire health sector, dealing with medical error. Well, there's also issues of the information systems themselves, as we become more dependent on them, as being potential sources of patient safety issues. The approach that we take at the agency is not one of trading off one for another, to say in order for information to be available it has to be less confidential or less private. Really what this is it's a process of optimization. Is that somehow we have to design our process, very much like a linear programming kind of problem, is that we want to have the most confidentiality, the most availability, the most integrity, privacy and safety that is possible in the design and deployment of our information systems. So this is how our privacy design starts off. Then we take a look at the actual people or the organizations that will use and manage the information in somehow. We call them information custodians. That's a term that comes out of the new privacy legislation, and health information custodians basically are all of the healthcare providers or anybody who actually has custody of a health information database. So you can think of all the healthcare providers, the doctors, the hospitals, pharmacies, labs. They are all health information custodians. And they've got to address privacy and security and safety risks in a number of dimensions. First of all, with respect to their people. The people who actually, and I'm talking people here, the people who actually deliver the health care. Are they properly trained? Do they have access to the proper tools? Is the user interface that's been designed for them to access, is it intuitive? Does it promote errors, or does it actually help reduce errors? A number of processes that very clearly have to be in place. Things like disaster recovery or business continuity planning, incident management, critical processes, technology. We tend to, in health informatics, focusing on technology fixes as the magic bullet or the silver bullet in resolving our problems. Our experience is probably technology is maybe 15 to 20% of the solution. The real solutions lie in your people and processes. But the technologies are very important. The use of encryption, the use of firewalls, of intrusion detection systems. We apply an awful lot of technology in the agency to protect information, but we also recognize that it's not the sole answer. And then, of course, there's the data itself. And understanding the actual attributes and quality of the data is really important. How sensitive is it? If this information was corrupted, what would be the possible impact? If this information was compromised or disclosed inappropriately, what would be the possible impact? Really understanding the sensitivity of the data and how it can be used or misused is really critical in our overall design. And then the top line here, is sort of bringing it all together, is we've got some guidance. It isn't just a guessing game when it comes to how do we design secure, private, and safe information systems. First of all, we're guided by legislation. There are several pieces of legislation in this province that are very explicit, particularly in the privacy domain, about how information is to be handled and managed. There's a large number of international standards that we apply in all of our agency products. In each of the three areas. In privacy, there's the CSA Model Code for the Protection of Personal Information that most of you, or some of you may have heard of. There's several key ISO standards with respect to security management, as there are standards related to safety management. So we rely very heavily on safety to provide us guidance in the development of our systems. Then there's the best practices. We find that there are organizations all across Ontario, all across Canada, and all around the world who are grappling with the same issues that we are, and many of them have developed solutions just like we're trying to develop solutions. So we try and draw on them wherever we can. And the last bullet there is innovation, because in healthcare and the deployment of the technologies that we're talking about, this is something very new. And we're constantly having to invent and innovate in order to apply our systems in a way that we can ensure the privacy and security and safety of our little patient here, our worried little patient here in the middle. So security, privacy, and safety as risk issues. Security, privacy, and safety are mandatory features of all SSHA products and services, as I mentioned. It's not entirely an issue of compliance with legislation and standards. A lot of people really focus on this whole paradigm of compliance, is that you go to a piece of legislation or to a standard or to some sort of specification, and there's a great long list of 137 items that need to be checked off. We find that that's not a very practical way of doing things, because in healthcare there's no cookie cutter. Every environment is somewhat different, and there's a real need to balance the operational demands and the real risks associated with the environment with the real business risks. And the business risks vary from a disclosure of personal information through to an information system or critical information not being available when it's actually required for critical care. So we're constantly trying to balance those, and really moving from a compliance paradigm, the checklist, to a risk management paradigm, where we're looking at all of the environmental factors, all of the interests of the patient, and trying to make sure that we have maximized or optimized, all of those issues. I like this little thing here. Just I'm going to talk a little bit about privacy here. This says, "I'm now cutting all my rude remarks about the patient from her file." This is, sort of rather. This speaks to the issue of privacy and the fact that healthcare organizations, healthcare practitioners have specific obligations with respect to personal information and protecting the interests and the rights of individuals. Obviously, this wasn't being done in this case. So what are some of the issues, the very practical risk issues that we've run into in the privacy arena? Well, first of all, in the privacy arena, we're managing compliance with multiple authorities, and this is there's a real alphabet soup when it comes to privacy legislation at both the provincial and federal levels that have to be addressed. At 100,000-foot level, all privacy legislation looks the same. But when you actually get down to implementation, there's a lot of very subtle differences. How consent is handled in this piece of legislation called PIPEDA, the Personal Information Protection and Electronic Documents Act, which is a federal act, is somewhat different than how the Personal Health Information Protection Act here in Ontario handles things. So we're constantly juggling the dissonances that we have amongst multiple authorities and having to make choices about how we're going to actually implement our systems. We also have an issue of defining privacy responsibility in a multi-organizational information sharing environment. When you have a health information transaction, it can pass through multiple organizations, and it's really hard to determine who's responsible for the transaction at any point in time. A doctor sending a message to a lab that will end up in a patient's hospital files, flows from the doctor's office, which is one environment under one particular set of standards or specification, flows through the Smart Systems Network. We're governed perhaps by other legislation or authority, goes to the lab, which is, again, another completely separate environment, back through the Smart Systems Network, and then back to the hospital. Managing information at these multiple points we find very, very tricky and requires close collaboration. And as a result, you might have heard of something called the Privacy Impact Assessment. And we've actually had to reinvent this. This is a process very similar in concept to what you might be familiar with as environmental impact assessments, where somebody wants to take a factory and put it in the middle of a swamp. You need to have a environmental impact assessment to understand what the impact is on the flora and the fauna and the air quality and water quality and things like that. Very similar with respect to an information system going into a clinical environment. You're adding the new or putting the new information system in. Is it making information more or less secure, more or less private? Is it respecting the patient's privacy right in how it handles consent or how it handles uses and disclosures of information? The Privacy Impact Assessment is a structured process that allows us to track information from its actual creation or the collection of the information through its use, all the potential disclosures, the retention, the eventual destruction. And you'll notice this is the life cycle of information. So we try and map the life cycle of the information that's in the system and then identify any privacy risks that might exist. And then that results in a number of recommendations. So privacy represents one of the domains that we go through some very specific analysis on. Second one, we actually start talking about security. This is going to buy some personal information. This never happens. In the security domain, what are we looking at? Well, we're first of all trying to understand the threat environment. Who are the bad guys out there who might actually want to do some damage or do some harm to information systems, housing personal health information or personal health information itself. And this could be everything from not just individuals. It could also include natural elements. Are there things like power failures or floods or pestilence, all those kinds of things. You have to understand what the threat environment is in order to establish the appropriate countermeasures to protect your information systems and the information in it. Another key element is identifying the actual assets, is that if you don't know what information that you have, you don't know or you won't notice when somebody has stolen it or damaged it or compromised it. This is very typical in large healthcare organizations where there could literally be hundreds of databases scattered right throughout the organization, such as a large teaching hospital, for example, that unless you happen to know where all of those information sources are, you won't know if it's being compromised. You won't even know to go and look. So identifying your information assets is a key element. Security is also addressing more than just confidentiality. People tend to focus on the confidentiality issues, but probably as or more important, and I would actually argue that it's more important in the health information domain, is making sure that the information is available and it maintains its integrity. It's highly unlikely that somebody is going to have their health seriously harmed if there's a breach of confidentiality. But if information isn't available when it's required, or if the information has been corrupted somewhat, for example, if you could imagine a lab value being stored incorrectly in an information system, that could have disastrous consequences for the individual. So we have a process at the agency called threat and risk assessment, and I'll actually just jump here before, and I'll just get to the other one first, where it's a structured process, again, just like the privacy impact assessment that we go through to identify our assets, to make recommendations, and you can sort of see here that it's a cyclical process. This isn't something that you just do once. We're doing this continuously in the agency. Something to think about, or another way of thinking about security in the healthcare sector, is if we sort of think of what happens in the financial sector, where we've got a need to protect money, basically. If you look at each of the different environments that you're in, it's actually quite different. How you protect information in your home, you might put it in a cash box, maybe in a locked drawer or something like that. If you're in a high crime area, you might have an alarm system in your house. That's probably as far as you would go. If you're in a retail store, you might have a safe, because and you might have certain procedures, alarm systems in place in case somebody comes in to try and rob you. If you're a Brinks truck driver, or you've got another set of issues because you're actually moving around. And of course, if you're a bank, you've got vaults of 3-foot concrete or 1-foot steel protecting the information. This happens because each of these environments has a different set of circumstances, and as a result has a different requires a different set of countermeasures. And if we can think of applying this in the healthcare environment, we can't apply a cookie cutter approach. A small doctor's clinic will never have the same security issues as a large teaching hospital or a visiting nurse or homemaker who happens to be driving around with a patient record in the car. It's really necessary to go through some sort of a structured process in each of these different environments to identify the risks and then deal with them appropriately. Last one, I like this one here. I'm just going to get in. into the issue of safety here. Safety is actually the newest area in our area of risk assessment. I refer to safety, or the lack of it, as the silent killer. We talk about health information systems, as I mentioned earlier, as being one of the enablers of improving patient safety through providing better information, better decision support to health care providers. But we're actually quite concerned at the agency that the systems that we're building ourselves might actually cause problems. For example, if one of our networks went down during a telemedicine session, we have a telestroke network here in the province where it's absolutely critical that that system be up and available 7/24 at an extraordinary high level of reliability. If that system actually goes down, somebody could be harmed. If you think of the Ontario Lab Information System, if a lab value is stored incorrectly in the database, again, a patient can be harmed. So we're starting to look very closely at the whole question of patient safety as it relates to the actual information systems itself. And what we found in our sort of international search of things is that it's not currently addressed in any organized form anywhere. There's a lot of literature about patient safety with respect to diagnostic devices and drug interactions and that, but when it comes to the actual information systems themselves, it's not there. So we're actually pushing the envelopes somewhat here by establishing our own standards for safety and evaluating our products and services. And this is a whole area where you will probably start hearing more and more in the coming months and years as we start to understand the safety implications of health information systems, of the electronic health record, other electronic means of communication between healthcare providers. Just a brief thing on the certification and accreditation process. Once you've gone through these three processes that we have here, the hazard risk assessment, privacy impact assessment, and the threat and risk assessment, you'll notice that there's a recommendation section. It's a question of what do you actually do with it? So what we do at the agency is that we've established a risk management framework. This is a busy slide, but I'm only going to focus on a couple of things here. One is these are our processes here, the PRA, TRA, and HRA. They show us some element of residual risk. Now, if we find that there are no risks or very low risk associated with the system, we just move through a process. We certify the system and then we accredit it, which means the organization officially accepts the system and its associated risks. If you have medium or low risks, we create what we call a waiver. And what a waiver does is basically tells us, or it's a document that describes how we're handling the risk. This is part of our openness and transparency, is that we've got to be able to report to any healthcare provider who asks us, what are the risks associated with using the Smart Systems Network, and what are you doing about them? Well, that's what the waiver does. And with the waiver, we can do three things. We can accept a risk. In some cases, we have to. There are some risks that we can't mitigate, or we can't mitigate without compromising something else. If there's a risk of a disclosure of information, for example, but the countermeasure really, say, degrades the integrity or the reliability of the system, well, we're going to make the choice to make sure that the system, the integrity and the availability are protected, potentially at the expense of confidentiality. So in some cases, we might accept the risk. In other cases, we'll what we call transfer the risk, where we'll just make it known to the hospital to say, okay, there's some issues here. You can use it if you want, but we're at least being open, disclosing to you what the risks are. So the hospital or the doctor or whoever it is would actually take on that risk. More typically, we look to mitigate the risk, where we come up with a plan, and this is what the waiver document does, is that it has an executive accountability. So some executive at Smart Systems actually has their name attached to it and are on the nut for making sure that the risk is managed or fixed. There's a mitigation plan and a timeline for all of these risks that are defined. So this is basically how, at the agency, we handle any of these residual risks that we found through these processes. Now, what's really important is not to, in designing a risk management framework, is not to be arbitrary in any way or subjective. What we really try and do is lock to something very concrete in establishing our risk risk measures. The standards that we use at the agency are on security. There's a standard called ISO 17799, which is the Code of Practice for Information Security Management. It's a widely accepted international standard, accepted in the health sector right throughout the world, as well as many other sectors, the finance, manufacturing, the governmental sectors, quite a few. On the privacy side, we've got the CSA Privacy Code, we've got the Personal Health Information Protection Act, the Freedom of Information and Protection of Privacy Act, and PIPEDA. These are pieces of legislation that we actually lock our risk management analysis and assessment to. And on safety, there's some draft standards for health information systems hazard classification, and we're actually participating in the development of these standards at the international level. So standards is an important part of your risk management program because, as I said, you don't want to be arbitrary or subjective to the extent possible. There is a little bit of subjectivity in it, but we really try and focus on the concrete. So with that, I'm going to turn it back to Mike.
Just I want to go back to Brendan's picture of the bank and the house and stuff for 2 seconds. And there's no such thing as a completely secure system. There's no such thing as a risk-free environment, right? And what we found when we started dealing with the health sector, and with, in particular with information technology, I'm going to call them tech weenies, right, was that they couldn't differentiate between your house, the Brinks truck, the branch of a bank, or Fort Knox. Right? They sort of said, well, absolute confidentiality, absolute security, absolute everything. And of course, it costs an awful lot of money to put all those machine guns and whatever around Fort Knox to protect the billions and billions of dollars worth of gold, and you're not going to do that to everybody's house. So it's been a very interesting balancing act and very difficult thing for us to get the techies to realize that you have to evaluate, does anyone actually want this information? Is there any probability anyone will ever steal it or try to steal it? And if so, what could they possibly get? $50 or $50 billion? A huge difference, right? So we've had some very interesting, seems obvious, but the reality is when you actually deal with the people trying to implement these systems, they tend to go to the extremely expensive, extremely hard to implement solutions to the extent that it can damage the patient. Okay? And so we're trying desperately to do. There's an example, I'll give you one example of it. In this province, there's a lady, who I won't mention who it is, well known in the province, who's had some brain surgery, ended up at a hospital on University Avenue, had brain surgery, everything was looking fine, ended up on University Avenue, was in the merge. They needed to do surgery on this lady right then and there. They knew that her records were at Sunnybrook Hospital. They phone up Sunnybrook. Sunnybrook says, yeah, we've got all the records, we'll collect them all up. Her husband gets in the car, drives to Sunnybrook Hospital. They won't give the husband the records. Seriously, this true story. They would not give the husband the records. The husband saying, look, my wife's down there being prepped for surgery at UHN. You've got to get these records down there. They phoned a cab. They gave the records to the cab driver. And the cab driver drove off and was never seen again. And the person was operated on without any of these records. Now, I've used the hospitals, aren't necessarily really the hospitals that are involved. I've just used a couple of examples of large hospitals. This is a true story, happened in Toronto to a very well-known person in our society. And fortunately, the operation was okay. But think of the ludicrousness of a person undergoing brain surgery, and they wouldn't give the person's records to the husband to take to the other hospital. And why? Privacy issues. Anyway, so we're trying to deal with these things, trying to get pragmatic, reasonable intelligent decisions being made about patient care, because that's what it's all about. It's all about patient care. It's not if somebody tells me I'm about to die, but we can't open your file because there's some, we might be, exposing you to some privacy leak. Anyway, road ahead, what can you expect? Where are we going? Well, first of all, I'll tell you where we are today. All the hospitals in the province are connected up. All the community care access centers and all of their subsidiaries are all connected up. All the public health units are connected up and communicating. In the next year, we expect to connect all of the pharmacies and laboratories, all of a very large number of physicians' offices, all the long-term care facilities, a very large, very, very large proportion of the province's health sector will actually be connected up with broadband or better connections on a private network. Okay? So this is you may have a DSL connection, all right, but it's a private DSL connection. It's not some DSL connection that's going over the internet. Okay. Registration systems are they're currently some of them in place. Registration is extremely complicated. By that I really mean identity and access management. It's a problem, by the way, that has not been, in my opinion, appropriately resolved anywhere in the world with respect to a health system. And so we've taken a bunch of steps here in Ontario, and I firmly believe, having reviewed the stuff where they are right now, that we will be the leading jurisdiction in this area in the world at the end of this year. It's a very tricky problem. Email, I mentioned earlier, we want to have email out to all of the physical locations by the end of this fiscal year, which for us is end of March next year. Right? Basically, by that I mean we don't have everybody in the system on email, but if we wanted to send email to a location, maybe a nursing home, a long-term care facility, we could get that mail there and they could send things back, and it's primarily for public health reasons. Okay? We want to be able to have two-way communication with anybody in case there's something comes along like the World Health Organization talking about the bird flu, avian flu. We want to be in a position to do that. So that will be happening this year. Of course, email is sort of useless if you don't have directories, so the whole directories will be there, and a variety of applications that we've mentioned, such as emergency room access to a drug database for senior citizens and for people who are on social assistance, so that if you drop into emerge, they can look and see what drugs you're on and see if, help the physician there. The OLA system, lab test reporting, a whole variety of them. By the way, we have implemented a public health information system in the province. I don't know if I mentioned that earlier or not. That tracks communicable diseases. We also have a quarantine management system so public health. We're in pretty good shape, actually, with respect to public health in the province. Anything else? No, I think I'll just leave it at that. That's sort of where we're at. Going back to this whole idea of balancing that I talked about earlier, we're trying to balance delivery with privacy, with security and safety, and trying to optimize them, always keeping in mind that we're actually dealing with patient health here, and it has to be the heart of all of our thinking. We're dealing with sick people. We're trying to do the best for them that we can. We can't let some ideology stop us from delivering that care. So with that, I think I'll get Brendan to come up and do whatever we're supposed to do.
And I think you alluded to it as well, is that as a patient, being able to access my own patient record is critical. And the ability for that, the safest way for that information to be transported is by the patient right now. Right now, you go into a hospital, and if you've got charts and you've got slides and whatever, most hospitals will just say, here, take it, and for your next visit to the next place. So the question I have is, given that this is a private network with a private DSL, given that a patient wants to see their own private record, and the easiest way to handle privacy and security is to give that permission by the patient. How can Smart Solutions for Health provide a personal portal, patient portal for that?
Okay, let me talk to that. One of the projects that I mentioned very briefly, I think, is what we call client registry. Now, in the past, client registry effectively in Ontario was your OHIP card. We have a project underway to take that client registry and change it so that it has, it's more like your ATM card or the cards and the codes that you use for doing internet banking and things like that. So put a system in place whereby a citizen can in fact identify themselves with a significant degree of trust that I know it's you that's at the end of that telephone line, that's at the end of on the internet, coming in from the internet, and then you'll be able to link in and view records that are kept for you. Now, there's a whole bunch of policy around this that has to be worked out, mainly because the actual information you see isn't just your information, but it's an interpretation of your information by the healthcare provider. And sometimes they want to make sure that when that information is presented to the patient, that the healthcare provider is there. So there's all kinds of little policies around that. People who have mental illness, they don't want them to be rooting around and making incorrect assumptions about the information and various things like that. But the whole concept is, and there's a project underway which I didn't mention, is to get it so that we, in fact, everybody can access this information electronically. Now, that's the huge advantage to this, by the way, is in other areas that we never mentioned, health promotion and wellness. Okay? You could easily, if we had the record, okay, and we had the access to the information, and we knew who you were, you could get into the system. You could sign on to your Yahoo account, and we could have an arrangement with Yahoo so that you could securely be fed information on your health and wellness based on the content of your record. So we could look at it and say, this person has diabetes, and if they agree they want to participate in this, every time you go to check your email on Yahoo, right, something could come up and tell you about, the latest news on diabetes, or did you check your blood sugar today, or whatever. Okay? So there's all kinds of advantages to us connecting the patient to the system. I don't know about you, but when I phone to try and get an appointment for my daughter or my son to go see the doctor, sometimes takes days almost, because I get busy signal, and finally I get through, and it's wasted an incredible amount of my time. And by the time I get onto the line with the person, I'm frustrated. So there's all kinds of issues. We can do scheduling with doctors. There's a lot of automation that will occur when we get there. So the secret, though, is we've got to get that identity and access management for patients.
I've got a question about integrity of data and the integration between hospitals and physicians, their own systems, and the SSHA services. In IT, there's one of those things that we always say, if the same data is in two places, it's wrong in both, right? So, how do you deal with that? I guess one issue is, what's the authoritative source of information? How do you deal with if somehow, by some weird, wacky reason, information in two places suddenly becomes different? Which one's correct? And I guess related, I guess kind of a separate question, what determines what information gets shared? Is that a policy, or is that just voluntary? How does that all work? It's kind of a long-winded question.
Okay. As in most things, there's a bunch of trade-offs with respect to how do you allow people to get access to information and not have duplicate data, or if you do have duplicate data, making sure that that duplicate data is accurate. For instance, if you do backup of a database, you have duplicate data, and you trust that your database backup, it happens to be the same as the thing, and your whole system's dependent on that for recovery purposes. So the trade-off on accessing the data directly is that it's technically quite complex, not for a number of reasons, which I won't go into, but to do peer-to-peer connectivity and to do searches across hundreds of thousands of potential sources for data about an individual. So it turns out through doing the analysis that you're better off on, let's say, on a provincial basis to feed key information into a central repository and then control that repository and feed the information back up. There's a whole range of technical, it's been studied to death, and there's some good reasons for that. The issue, of course, is exactly what you said. You have to tag the data. You have to be sure that the movement from the doctor's office to the central repository is done correctly and accurately, and the data is not changed in that. And that's not that hard to do, actually. But then the second thing is you've got to be able to flag the data that this is, in fact, just a copy of that doctor's data. So the design of this thing basically says, I've got the doctor's data here, I've got the repository here. When I put the data into the repository, it's flagged as its source, where that source is, how you get it. There's an audit trail for it. So there's a whole process for ensuring that we can follow that trail back should the data ever get corrupted, or if people want to go back to the source and see if the source was actually entered incorrectly, because that actually happens more often than the other. You look at your data and say, this doesn't make sense. So you phone back the source, let's say it's a doctor, and the doctor says, oh, geez, that got entered into my system incorrectly. It was wrong in the first place, so wrong data got propagated through the system, more common than correct data being modified and changed. So that was the first part. Second part of the system was who determines what can be shared and what can't be shared. We don't have a very good governance structure for that at the moment. And what's happening right now is it's being dealt with on a sort of an ad hoc basis by the healthcare providers and the patients themselves. The concept is that if the patient agrees, all pertinent information that the healthcare providers believe is appropriate would be shared. Okay? The patients, though, have a right to say, you can't share this information electronically. You can put what they call a lockbox around this thing and say, you can't share that. Now, what's happening with the doctors is they're saying, yes, we understand that, but what we want to do in the electronic world is say, and this is the current thinking, it hasn't been implemented, and it's still lots of debate on it. They want to say, if Brendan comes to me, I'm a doc, and says, I'm going to trust you with a sort of custodianship of my record, but I want you to block this stuff off. And the doctor says to him, well, that's a risk. I know that if you show up in a hospital, that thing you want to block is a real serious problem from a medical point of view. Okay? And Brendan says, I don't care. Then the doctor says, well, I can't absorb that risk. You're asking me to do something that's, bad medical practice, so I'm not going to manage your electronic record anymore. So that's basically what the doctors have come back with. They're saying, if what Brendan wants to mask has very little risk associated with Brendan's health in the future, so I don't know, maybe he had a mole removed or something. He said, I don't want that. It was on my forehead, and I don't want that there. And the doctor would say, that's irrelevant. Who cares? He'd continue he'd mask it out of the record, okay, and let the record go forward. But if it's some important thing, like he's got an aneurysm or, then the doctor says, I can't leave that out of the record, because if you show up in the hospital, they'll probably treat you incorrectly because of some very important information that's missing. So it's that sort of thinking that's going on.
I think this is an area as well where there's mentioned there's good guidance that comes from that sort of that top layers that With respect to the privacy legislation, in terms of who's actually responsible, who's the source, well, the health information custodian, in this case it could be the doctor, for example, very clearly identified as the responsible person to make sure that that information at least is collected accurately and is transmitting it using some secure method. It's also an area where there's a lot of work being done on the standards front, and there's work happening at both, I mentioned the Ontario, the Canadian, and the ISO level to actually establish standards for communication of information, establishing standards for the coding of information, the acceptable methods for coding. So these are all parts of the overall solution. We're certainly not, we haven't achieved that nirvana state yet, but I think there's a lot of very positive activity going on that is really going to help us get there.
I want to ask a question about your responsibility or involvement in software quality standards. For example, to take a practical example, medical imaging systems that are either being developed in Ontario for use in hospitals in Ontario, or software to manage those kind of devices that's being imported from other jurisdictions. What's your role in ensuring quality of software development practices?
We have no role at the moment in that at all. Absolutely none. So,
Is that you view that as a risk?
is that viewed as a risk? I don't know. There's two sides to that risk. Okay. One side is that it looks like no agencies actually, or no government agencies actually looking at that particular problem and doing the assessment. The other side is, if we got in and started doing that, it's an area that A, we don't have an awful lot of skill and expertise in, and B, it would slow an awful lot of the stuff down. And to date, the systems that have been developed haven't shown an awful lot of risk in that area. So there's two different risks there, and I think at the moment the risk is let's let the market deal with that particular issue, because it hasn't shown to be a huge risk here or anywhere else. But
although I guess this goes back to what I was saying about the whole safety question, where this is an area where there's been very little work done, certainly in the health sector, and in trying to establish appropriate methodologies that we hope to be able to, it wouldn't be the agency's responsibility for a hospital information system, for example, but a hospital, the CIO, should be able to pick up some methodology and do their own assessment about, and ask questions about software safety and that sort of thing. So we do plan on providing some of the tools, but we wouldn't have responsibility for the actual assessment.
I don't want to belabor it, so it'll be my last comment, but most of the evidence that we have about software development is that it's a source of major failures in business and elsewhere. And it seems that unless there is action that's taken at a level above a hospital administrator, that there would be no standards developed for protecting the reliability, security, integrity, and safety of those systems. Most of and we know in healthcare, the systems have often failed and are miserable failures in many places. So it seems like it's got to go above, maybe at the level that you're operating.
I would like to comment on that. If you want a practical, real example, I won't mention the jurisdiction, but a diagnostic imaging system actually built in Canada, a standard product widely used in this jurisdiction, had a problem with its queue handling for diagnostic imaging reports. At the end of a period of a little over a year, this institution discovered that 2,000 cases had never been issued to the printer. They were in the queue. And a software error caused that. This only happened a year ago. In that period of time, physicians not receiving the diagnostic imaging reports often failed to do anything, forgot about it, because they waited as an event of care for those reports. It was a major embarrassment for the institution. And it's a straight software error, and it was predictable, and quality assurance standards could have detected it. So I'd like to mention it, and I have other examples of that as well, is that it seems to me that somebody should be looking at that, and I don't believe the expertise exists at the institutions to look at that. It might be an area that would be worth discussing, because it has been left behind quite harshly everywhere. So comment on that. Shirley?
Yeah, I have a question regarding your statement on IT infrastructure. You had mentioned that the data centers were having a big job in collecting data due to the differences of streams of data that were coming in and the quality of the hardware, perhaps, and software that's in their hands in these clients. Are you recommending any standards? Are there emerging standards so that, for example, doctors who are putting together these new family health teams and are going out buying software solutions, are there standards that they should be using for their practices?
Okay, I'll answer the last part of the question, and I'll try and go back to the first part of the question and clarify what I meant by that. Okay? The example with doctors is there are a set of certified products that have been certified by the government and the Inter-Medical Association folks together to, and only those certified products are ones that qualify for funding assistance through the family health teams and the various other funding parts of government for docs. So there are a set. They go through a formal testing process, and then they are the ones that are certified for funding, approval for funding. So there are like 300 or 400 different products, of which there's 14 or something that have been approved for funding. Does that answer that part of the question? Going back to the first thing, actually what I was talking about there was, I'll pick it, let me see if I can give an example. Email, integration of email. So I've got a lot of large institutions that have email systems, like, some of them, hospitals will have thousands or 4,000 or 5,000 people on that email system. We don't want to take away that, it's stupid. We wouldn't take that email system away and try and supply that email service to them. Maybe someday if they're changing technologies or something. But what we really want to do is integrate with their email system, get their directory, integrate their directory and their registration processes with our registration process and our directory, and publish the directory. Well, when we actually go out there to these institutions, we find out that they're all working, sort of obvious actually. They've all got different releases of the software. They've got different software. They've got email systems some of us have never even heard of, right? And they've got 500 or 1,000 people using this system. They've got different levels of directories, different types of directories, So there's a lot of different technologies that we have to go and sit down with them literally one-on-one and say, okay, how would I synchronize this directory with our master directory for the province? We have to literally do that on a one-by-one basis. We have to look at, go in, and sometimes we look at them and say, well, you don't have very good procedures for security or backup, or you don't have change management in place properly. So we sit down with them and negotiate and say, look, we can't really integrate you into the system until you fix up your environment. Right? Or in some cases, we look and say, we can't integrate this stuff until you either change your technology and or upgrade it to a more current level, because it just isn't any... So it's that sort of thing, okay? It's also the same, that happens at the net, it happens at every layer of the communications model. We run into it right down at the physical layer some places.
My question is similar to the email situation. With the electronic health record, is the intent to have one master system where you have one master record for the patient? Because in your one diagram you had one patient, one record. But with all the doctors and the hospitals and the healthcare providers all having their own information systems and different releases and different types of systems, how do we kind of manage, or what is your thoughts on managing that to create that one record?
Okay. Basically, we don't envision there being one comprehensive record. Okay? And the fundamental reason behind that is that the data, the vast majority of, for instance, hospital data about a patient, an inpatient in a hospital, has a half-life of a couple hours. I mean, nobody cares what the patient's temperature was yesterday at 2 o'clock in the afternoon, right, when the patient's been discharged. I mean, it's just, so the actual amount of data, if you went into the hospital looking at truckloads of data, you only need 3 or 4 simple things, okay, that you need to transmit. And the same thing if you looked at your medical record in a doctor's office. For treatment other than with that particular doctor, there's very little that's actually in your file that needs to be transferred over. with a few exceptions of those really chronically ill patients, and so usually they go to the same place, okay? And so they, to get treated, they're very, very sick. So we don't have to keep, 400 gigabytes of data for each patient. And we need to have a few things. We've got the doctors together and other healthcare practitioners who said, what do you really want? What kind of data do you want? And they say, we want the basic demographic data, we want their chronic conditions, and we want their recent lab tests, we want their drugs that they're currently on, any allergies, there's a whole list of stuff. And it's fairly easily definable and easily transferred from one application to another. And the interface is a published API, right? So that you publish an API and say, okay, you have to push to that API from each source. Okay? And it isn't all the truckload of data that's there. Did that?
Just a scuttlebutt question. I heard a rumor that SSHA was going to change their name, and I was wondering why, because it's such a great name. If that's the case.
We don't know if we're going to change the name. I'll be honest with you. I hate the name. Now, I came up with the name in the first place, but I hated it at the time. I had to do something like overnight sort of thing, and I couldn't think of anything. And I forget how we came up with the name. I've never liked it, but it now does have some brand associated with it. So I'll tell you why they're thinking about it. The change that we've made recently is this move from the government doing a bunch of stuff and us just doing infrastructure to us doing a whole bunch of the stuff the government used to do. And so they want to get, some people are saying, well, let's change the name so that we can get it clear to people that this agency now does an awful lot more than we originally intended it to do when we set it up. So that's the thinking behind it. The other side of the coin is they're saying it's got a brand, it's already out there. Why change it? Just advertise that it's changed, right? The function's changed. I hate the name, but I also realize that changing it's an awful pain. We've been doing an awful lot of talking to people over the years. You like the name? I hate the name. And I don't have a better one.
Rumor I heard they wanted to change your name.
I thought your slide was excellent, showing the trade-off of confidentiality, availability, and all those other features, and being governed by various legislation bodies and standards and best practices and so on. I guess my question is, as you develop your applications and make them available to different healthcare providers, you'll obviously make some design decisions about how you're going to trade off those various components. As a consumer, how are the consumers going to know which ones you traded off? So if you've got a person who's maybe heavier on the confidentiality side, how will they know that you've brought your product up to the level that they would want as they're looking at other possible competitive products that they might have to pay for?
Well, we do have in our design and all our design decisions, there's a large number of people involved in it. So it's now we don't have a large consumer base, unfortunately, because there's just no easy way of getting to them. But for example, the Information Privacy Commissioner's Office we would use as a proxy for protecting the interests of those people who are interested in the confidentiality issues, for example. And we'll have very, very intense, sometimes almost like blood on the floor kinds of discussion with them, but eventually coming out with a reasonable accommodation that everybody's comfortable with. Okay, we have adequately addressed the privacy issue while, but in consideration. Like, for example, if I can just use a concrete example of some of the trade-offs when you're dealing with public health, for example, where it's very clear that there are going to be some disclosures of personal information in the midst of an avian flu pandemic and that sort of thing. Even the privacy commissioners at all levels and all jurisdictions basically said that in a public health kind of situation that will definitely trump the privacy issue. So we do consult very widely. Certainly, the healthcare, the leaders in the healthcare community, the OMA, the OHA, they are all very much involved and very patient-centric in their thinking. So we're comfortable that we would withstand public scrutiny at a minimum around any decision that we've made.
Can I just follow up on that one for a second? Okay, we're the delivery arm, the ministry's the policy arm. So let's take an example. What level of security do we need for an email system? Okay? Or what level of security do you need for a telehealth application? Right? We actually do this study of what we need, what's practicable, and go back through that Ontario eHealth Council and make that recommendation to the ministry, and the ministry actually sets the public policy on it. So it's not us doing it. So it's not us doing it. I mean, we're doing the work to make recommendations, but the actual public policy gets made by the ministry, and then we get to implement it. So that you asked earlier, you were saying, how do we know how far to go? Well, we give the pros and cons of all this to the policymakers, which are the government.
Yeah, I guess if I could just sort of tell you where my question was coming from, I think how that will play out in hospitals, and that's where I come from, is you'll have a lot of privacy office questions to the local IT department saying, does this meet our local hospital standards and that sort of thing. So we'll have to have a way of conversing back and forth and figuring out how that plays out, I guess.
Unfortunately, I've got 6 questions. I can't ask them, and we don't have any more time. So unfortunately, at the cutoff, what we'll do is invite you to come down and talk with these guys for a couple of minutes. I don't think you beat them up enough. I think we could have had more fun with them if we had a chance. But Mike, thank you very much for your talk. Brendan, thank you very much. And I'll turn it back over to Shirley.
And I thank you as well. I just want to remind you again, please come out in June on the 22nd to hear Sam Marifiotti. I know he's a very entertaining person, and he'll give a great talk, and we can only learn more by listening to him on his comments on eHealth in the province of Ontario. So please join with me in giving our thanks to our speakers at this time.
Just mention, if you haven't heard about our boot camp yet this summer, you might want to get information on it. And anybody that doesn't yet have information, it's a 1-week intensive course in applied health informatics. We'd welcome questions on that. It's on our website. And please, if you're interested or if people are interested, let us know soon because it's filling up quickly.
Okay, that's it. Thank you very much.